Hello everyone, my name is Chen Liangge, and today I'm pleased to present our research titled Neutrophil-to-Lymphocyte ratio as a predictor of cardiovascular mortality in cancer survivors. This article was also co-authored with my colleagues from the first affiliated hospital of Guangxi Medical University. Advancement in cancer treatments extend lives. We are seeing a growing population of cancer survivors. However, this success brings a new challenge: unattended surge in long-term cardiovascular complications, often due to cardiotoxic effects of therapies. Despite significant strides, a critical gap persists in identifying precise biomarkers that can predict cardiac mortality, specifically within this vulnerable group. This highlights an urgent need for innovative, readily accessible prognostic tools. The neutrophil to lymphocyte ratio, or NAR, has emerged as a promising candidate. It is a straightforward and readily accessible inflammatory mark, calculated by simply dividing the neutrophil count by the lymphocyte count. Elevated NAR is consistently associated with poor outcomes across a range of conditions, from cardiovascular disease to various cancers, underscoring its role in systematic inflammation. However, its potential in especially forecasting cardiac mortality among cancer patients remains unexplored. Therefore, our study aims to evaluate NAR as a predictive biomarker for cardiovascular mortality among cancer survivors, utilizing data from the National Health and Nutrition Examination Survey, or NHANES. To investigate this, we conduct a new retrospective cohort study using data from the enhanced spanning from 2007 to 2018. As you can see from the flowchart, from our initiated dataset of over 100,000 participants, we identified 5,661 cancer survivors. After excluding those without NLR deaths, our final analysis tip cohort comprised 4,974 cancer survivors. Cancer diagnosis was self-reported and confirmed by a physician. Exposure was the neutrophil to lymphocyte ratio. We determined an optimal NAR cut-off point using maximally selected rank statistics to differentiate high versus lower NAR groups. The main outcomes of interest was all-cause mortality, cardiovascular mortality, and cancer-specific mortality, identified by linkage to the National Death Index. For statistical analysis, we employed Cox proportional hazard regression to calculate HR, adjusting for potential confounders in two models. Model 1 adjusted for key demographics and smoking. while Model 2 additionally adjusted for a range of pre-existing commodities. We also use Kaplan-Meier methods for survival analysis and restricted cubic spilines to explore potential nonlinear associations. On a cohort of 4,974 cancer survivors represented on U.S. population, the optimal NAR cutoff to differentiate groups was found to be 2061. As highlighted in this table, participants in the higher NIR groups compared to the lower NIR groups were significantly old, more likely to be male, and of non-Hispanic white ethnicity. They also had a higher prevalence of comorbidities such as heart failure, coronary heart disease, and hypertension. A median follow-up of 7.66 years, we observed significant association between NAR and mortality. In our four adjustment models, each unit increase in NAR was associated with a 10% increased risk of all-cause mortality and a 12% increased risk of cardiovascular mortality and a 6% increased risk of cancer-specific mortality. When we categorized NAR using the 2061 cutoff, the higher NAR group had a 38% higher risk of all-cause mortality, a striking 63% higher risk of cardiovascular mortality, and a 45% higher risk of cancer-specific mortality compared to the lower NAR groups. All these findings were statistically significant. Further explore the nature of this association, we used restricted Kubo's length. This plot visualized the relationship between NAR and mortality, adjusted for confounders. As you can see, for all cause, cardiovascular and cancer-specific mortality, the relationship is nonlinear, with distinct thresholds beyond which the risk of death sharply increases. For instance, for cardiovascular mortality, the risk significantly rises beyond an NAR of approximately 2025. This suggests that specific NAR thresholds are clinically relevant. Kaplan-Meier survival analysis further confirmed these findings. Participants in the higher NAR group demonstrated significantly lower survival rates for all-cause mortality, cardiovascular mortality, and cancer-specific mortality compared to those in the lower NAR group, with all log-rank tests being highly significant. We then conduct subgroup analysis to explore the association of NAR with cardiovascular mortality across different demographic and clinical groups. Elevated NAR was significantly associated with increased cardiovascular mortality in participants over 70 years old, in men, in avid smokers, and in those with hypertension. Interestingly, this association was not significant in their respective counterparts. although the tests for interaction were not significant, suggesting NAR's predictive power is modulated by these factors rather than qualitatively different. When we look at specific cancer types, elevated NAR was consistently associated with increased all-cause and cardiovascular mortality in survivors of breast, prostate, non-melanoma skin, colon, and melanoma cancers. For non-melanoma skin cancers and melanoma, this also extends to cancer-specific mortality. This suggests NAR's prognostic utility across several common cancers for cardiovascular outcomes. Discussion. Our study provides compelling evidence that an elevated NAR ratio is an independent predictor of increased all-cause and, importantly, cardiovascular mortality among cancer survivors. The identified cutoff of 2061 and the nonlinear nature of this association highlight critical threshold for risk. These findings have significant implications. NAR, as a simple and cost-effective marker, can help identify cancer survivors at higher risk for cardiovascular death. This offers a valuable tool for risk stratification in the growing field of cardio-oncology and could potentially guide more personal monitoring and intervention strategies to mitigate cardiovascular risk in this population. Studies have several strengths, including the use of large nationally representative enhanced cohort and comprehensive adjustment for a wide range of potential confounders. A key strength is its focus on cardiovascular mortality, addressing an important gap. However, we acknowledge limitations. The observed design means we cannot infer tragedy. While cancer diagnosis were physician confirmed, they were initially self-report. We also lack detailed information on cancer staging, specific treatments, modalities, or concomitant medications, and the timing of NAR measurement relative to cancer diagnosis or treatment was not accessible from the enhanced dataset. Conclusion. Our findings support that an elevated NAR ratio is a significant and independent predictor of increased mortality in cancer survivors, with a particularly strong association for cardiovascular outcomes. ANR acts as a pivotal prognostic tool, offering significant implications for clinical practice in the realm of cardio-oncology. Integrating the simple biomarkers into risk assessment models could help clinicians better identify high-risk individuals and tailor strategies to optimize outcomes at the next of cancer treatment and cardiovascular risk management. Thank you. I'd be happy to answer any questions you may have.